recording. There it goes.
There we go.
Oh.
And are you going to start with the first few slides, Martha?
Martha, you're muted.
I did that whole spiel muted. Okay. Well, hello, everyone. I'd like to welcome you to today's presentation on the psychosocial impacts of long COVID on patients and families. Before we get started, just a few housekeeping items. You could go to the next slide, please, Kata. Thank you. This session is being simultaneously interpreted into Spanish. To select the PowerPoint presentation, either in Spanish or English you would like to view, at the very top of your screen, there is a tab labeled View Options. Click on that View Options tab and a drop-down menu will appear where you can select either the English or Spanish PowerPoint presentations to view. Likewise, to select the audio language you prefer to listen in, at the bottom of your screen on the Zoom toolbar, there is a globe-shaped icon. Click on that icon and select the language you want to hear. Next slide, please, Kata. It's a reminder to our audience that this presentation has been approved for continuing education by the American Nurses Credentialing Centers Commission on Accreditation and the American Academy of Family Physicians. In order to claim credit, attendees must submit the post-session evaluation that will be shared at the end of this presentation. Next slide, please, Kata. In order to remain in compliance with the accrediting agencies, I do need to read the disclosure of relevant financial relationships. We have no relevant financial relationships that relate to this presentation, nor do we have any relevant financial relationships with ineligible companies whose products or services are related to pertinent therapeutic areas. Next slide, please. This webinar is supported by the National Institute of Environmental Health Sciences. Continuing education is being sponsored by Pfizer, and the content we share today does not necessarily represent the view of NIHS or Pfizer. Next slide, please, Kata. And with
Thank you,
that,
Martha.
I'm going to let you take it away. Go for it, Kata. Thank you so much for being here.
Yes, thank you. So I'm just going to repeat these learning objectives, which most of you have already read or you wouldn't be at this webinar. So primarily, I'm going to be focusing on the challenges facing patients, families, and caregivers during and after a long COVID diagnosis. And I'm going to be providing some explanatory frameworks to account for the really significant suffering that individuals who have long COVID and their family members experience. And then, try to provide some ideas about what family members can do to be supportive, what clinicians can do. Now, I'm well aware that some of you on this webinar have had family members who've had very challenging courses with COVID itself. Perhaps were hospitalized, were in ICUs, or you've had patients you took care of in that circumstance. And I also know that some of you are yourselves dealing with long COVID or are a clinician with a practice of long COVID patients or a family member. And so for all of our witness-to-witness webinars, we really encourage you to check in with yourself, see how you're doing, take a break if you need to. You're going to get the PDF of these slides. The link to the recording is going to be sent to you, so you aren't going to miss anything if you take care of yourself. And that's really our strongest priority, which is that you listen to the material in a way that takes good care of you as well. So one of the points that I'm going to be making throughout the webinar is that we are still very much in a confusing situation. So a new study that I read last week in the Annals of Internal Medicine reviewed 38 publications, and within those 38 publications, there were 5 distinct definitions of long COVID. And what we know is if we can't clearly define in a singular way an entity, it's going to produce complications and confusions, not just for the research that we need to understand long COVID better, but it's also going to make it very confusing for clinicians. And what we don't know is whether without a single definition of long COVID, we're actually comparing apples to oranges. And this form of confusion, definitional confusion, is actually going to be a thread continuing through all of this presentation. So another very important study last week was a banner week for long COVID research publications. This one was in Nature Medicine, and it looked at major outcomes for a large cohort, 135,000 people who had had COVID. And here, this is important to underscore. It was people who had had COVID before the availability of vaccine. And what the study found was very, very, and you're going to see the picture of what very, very looks like, very strong, significant difference in outcomes between those who had been hospitalized because they had had severe disease and those who had had a mild or a moderate COVID course. So here, ta-da, that's what that very, very different, significant looks like. You can see that the red line represents the excess death of people who were hospitalized with COVID-19 going out 360, that's year 1, year 2, and year 3. And what we see is the really strong divergence in major adverse outcomes over time. So how were these major differences in adverse outcomes described, written about in this article? So what they said was that the outcome differences included death, which was the graph that we saw, multi-system sequelae, and disability. And these were persistent at a 3-year follow-up in people who initially required hospitalization, which is a proxy for saying had severe COVID. And so one conclusion is that it shows that severity of the acute infection, as well as the response of the host, that is the person who had COVID, play a critical role in subsequent outcomes. And by contrast, the people who had mild to moderate COVID and who were not hospitalized really showed evidence of very small residual risk. So now we can look again at a different form of the graph. And what we see from the Pulse survey that was conducted around between 2022 and March 4th, 2024. And the question posed was whether they had ever had symptoms of long COVID or not. And what we see is that 6% of adults report symptoms 1 year after a COVID infection. Okay, so you don't have to do the math because others have done it for you. But that means that approximately 14 to 17 million people are living with long COVID now. And that's, from my perspective, That is a staggeringly high number. And towards the end of the presentation, I'm going to break that down in terms of the question of, well, how many long COVID doctors will we need to take care of, let's say, roughly 15 million people? So again, here are some conclusions. Now, this is kind of at the big picture, looking far out. We're not really focusing for the moment, but we'll get there on individual patients or families or providers. But big picture, long COVID is widespread, 14 to 17 million people. That is a lot of people suffering. Its incidence varies markedly across subgroups in the US population. But for many of us, many of you, you are specifically interested in, okay, well, what is the rate of long COVID for essential workers or farm workers? And the answer is, we don't know. We do know rates of COVID for essential workers and farm workers. And so we could do some back of the envelope extrapolating, but at this point, we don't have numbers specifically for essential workers or farm workers. We also know that long COVID is much higher among women than it is among men. It varies by ethnicity, and it's highest among whites. Now, when I present this finding at other times, people say, well, how can that possibly be? And I'm not a researcher, so I don't know the definitive answer. But the one that I have read is that many of the people initially, before vaccine, who had severe COVID were brown and Black people who were essential workers or farm workers who were exposed to COVID, and more of whom then died, meaning that they are not alive now to have suffered with, come down with long COVID. It's also a hump-shaped curve in that the group, the largest percentage of people managing, suffering with, coping with long COVID are middle-aged. And finally, and I find this very interesting and puzzling, long COVID varies by location. It's highest in the South and lowest in Hawaii. And one other association is that this particular graph, when you look at it, maps on, some researchers think, with graphs of happiness. Hawaii is the considered, or research shows, it's the happiest state in the US, and they have the lowest rate of long COVID, whereas West Virginia and Mississippi show up on happiness surveys as not so happy, and they have the highest long COVID rates. I don't really know what to make of that kind of correlation, but it was included in this recent article. So this is a kind of another way of looking at the question of farm worker, essential workers, people who are non-citizens. And what we can see here, the photo on the left is of New York City zip codes, mortality rates for COVID-19. On the right is the same, but in LA. And what we find is that non-citizens had the highest, or the zip codes that showed the highest COVID-19 mortality rates were in zip codes that had higher percentages of non-citizens. So what does a set of photos like the two previous graphs or photos show us? And I think what it illustrates is what we know from many, many, many other situations. And that is, if you are a sick immigrant, you can look at the yellow rectangle, it's likely that you are going to have inadequate healthcare access. Your healthcare is likely not to be culturally appropriate. And so it's likely to lead to a poor outcome. So the previous slides were giving you kind of a big picture look at what's out there, why is it out there, what's going on. And now I'm going to kind of focus in much more at the individual patient, family, and provider level. So many of these, there's a lot on the page here, but the overall for this slide and the next, what I'm really trying to convey is how confusing the sequence is when somebody comes down with what, well, let's just say with a viral illness. So I've posed these as a set of questions. The first of which is, well, am I really sick? Or if you're the family member, is my partner really sick? And okay, well, what? Does the person have a cold, the flu, RSV, norovirus? Is it COVID? So, okay, should the person get a COVID test? Well, where can I get one? And are PCR tests available or a rapid test? And even if I can find them, how long is it going to take for me to get the results? And what do I do while I'm waiting for the results? Okay, now we found out I got a COVID test and I tested positive. Well, can I isolate? Should I go to work? What do I do? Do I tell my employer? Well, how am I going to manage my household if I have children? Who's going to take care of my kids? And even more perplexing, if my child is the one who came down with COVID, well, how do I isolate a child? How do I make sure that the child doesn't come into contact with any other family members? And now they're telling me that I have to isolate my child for 5 days. Well, good luck. I don't know about your child, but my child is not going to be happy being in a room alone. Or wait, my child doesn't have a room, a bedroom by themselves. So this is all a very confusing situation right from the get-go. And it continues. So how do I monitor for serious illness? Well, how do I keep the person comfortable? And now I'm confused because I don't know when to call my PCP if I'm lucky enough that I have one. And I don't know if I should be going to urgent care or the emergency department. And now I read somewhere, my neighbor said, oh, if you have an underlying medical condition, it could be much more serious. But which one matters? And now I've also been told that there's a treatment, but I don't know whether my family member or I qualify for the treatment. And then somebody else told me, well, if you're going to get a treatment, if you qualify, you have to get it right away. But it's going to take days for me to figure out who I call, how I get it. I might have to drive a long distance, and I don't even know if it matters. So here, the overall situation that I'm trying to describe is that it can be completely confusing, even just in the scenario of managing a COVID diagnosis. And that's long before we get to, but it sets up some of the issues for patients, families, and providers by the time they do get to a situation that might or might not be long COVID. So now we're going to sort of look at the transition from acute to long COVID. And here, it's necessary to say that that transition is likely to be different if the person had a mild or moderate case of COVID, was able to isolate for a few days, versus a serious case, was very sick for 10 days, 3 weeks, or even so serious that the person was hospitalized, and then even more different in that transition from the acute phase to possibly long COVID if they were in an ICU. So again, patients and families are often uncertain about what's going on in what may turn out to be a transition from an acute to a long COVID experience. So after any viral illness, people are often tired. So how tired is tired? How long is it normal to be tired? People say to themselves, I'm just not thinking very clearly. I can't remember things. But then the same or similar question arises. If I have a healthcare provider, when do I say, I think I need to see a healthcare provider? Or do I say to myself, well, of course, this is going to resolve in time? So for the patient, going through a process of trying to figure out whether they're transitioning from an acute COVID illness, which will resolve in time, or whether the lingering experiences they're having, often experienced as fatigue and just not thinking clearly, really signify a transition to long COVID. And likewise, now going back to the initial slide where I said there were at least 5 definitions of long COVID. If the patient has come to you as a healthcare provider, you're going to have some difficulty because you are working with at least 5 different definitions of what constitutes long COVID. And when in your particular facility, what the timeline is at which you're able to say, these are symptoms that you're having that are either, you could say, maybe long COVID, likely long COVID, are long COVID. So again, there's no universal definition at this point of what is and isn't long COVID and when the starting line begins. And then what we find is in that period where there really is lack of clarity, and there have been many anecdotes about people who say that their symptoms were greeted with skepticism, or the provider was frustrated because there were no clear definitions. So the whole team, patient, family members, colleagues, employers, healthcare providers are often now either they're frustrated, they're skeptical, and some people have said that their provider has just said, oh, you're just anxious, you were sick, and now, go home and forget it. But we also know that there are just not very many specialized services yet, and there are very long wait times for service, even if you live near a center. So now I'm going to share with you the back of the envelope math that we did this morning. So we found, and we have this as part of our resource packet, a list of specialized long COVID clinics, and it came to 411, but we used 400 to do this little math problem. So again, if we take 15 million as the number of people who are estimated to have long COVID, that would mean there would be 36,000 long COVID patients per clinic if those patients were distributed evenly among the 400 clinics, which we know is not the case. An average clinician, a PCP, has a panel of 2,000 patients. So that would mean in any clinic, you would need 18 PCPs to handle the long COVID patients. And if we then do an estimate of the likelihood of that being what's present at any of these clinics, sadly, we come up with the number 0. And if somebody has a different math or way of doing the math, that would be great. Put it in the chat. So again, sort of what's happening? What do we know about the science of long COVID? Well, again, very recent research from UCSF shows that little pieces of the COVID-19 virus can persist in blood and tissue for more than a year, and even in tissue samples for more than 2 years. And what this means is, and we're going to sort of focus on the top part of this picture of this slide, excuse me. And obviously everybody would hope that they would have an acute COVID-19 infection and it would move into full recovery, and that would be that. You'd be sick for 3 days, 5 days, 10 days, but you make it absolutely full recovery. But long COVID is a very different kettle of fish. And here is a more recent photo or picture rather in this slide. And it breaks it down. On the left, we see 3 clusters of symptoms. So cardiovascular symptoms, neurological symptoms, and metabolic symptoms. And on the right are the 6 proposed mechanisms of why these symptoms are happening the way they are. The first one, viral persistence, is the one that goes along with that new study from UCSF, that there may be there is persistence of the virus in both blood and tissue. Another mechanism is that there can be immune dysregulation, and we have an increase in immune reactivity. The microbiome may be impacted, impairing gut-brain signaling. There may be inflammation inside the vessels, and that this may account for the fact that we know that people with long COVID often present with blood clots. There can be inflammation of neuron cells. And then finally, there's a strong hypothesis that dysfunction of the mitochondria may impair metabolism and may be the kind of the mechanism that leads to fatigue and metabolic symptoms. So which family members can get COVID? And I'm afraid here it's everybody. And this is a article that appeared looking at, well, what are exactly, when you ask patients 6 months after their acute COVID infection, what is it exactly that they are complaining about the most? And I have to say that this absolutely maps on to what I hear from friends, family members, colleagues, from reading anecdotal reports. It is the post-exertional melees, whether you're feeling worse after just even walking up 2 or 3 steps, or just doing a little bit of reading for work, or the experience of fatigue, brain fog. And as you look down the list on the left, you may recognize symptoms reported by people you know or treat. And then I've kind of taken those and said, okay, well, from the perspective of living in a family, what in particular is particularly problematic? And what we find is that the symptoms of brain fog, fatigue, that people describing, I just can't concentrate anymore, difficulty staying organized, their memory, difficulty breathing, are the symptoms that really do seem to have an impact on the person and on the family. And then here, these last two, depression and anxiety, it's actually kind of unclear whether these are kind of original symptoms that are part of the long COVID symptom cluster, or whether they are a response to the symptoms, or maybe it's both. But so often when we talk to people who have been diagnosed with long COVID, they will describe themselves as depressed. And if they describe themselves as anxious, what we find is mostly what they're anxious about is, will they ever recover? And that question, will they ever recover, is linked to an experience of self-loss. And here I'm I'm going to pause for a moment and say the next 3 slides are the ones in this presentation that we hear a lot of feedback to, because it kind of crystallizes an experience that many people with not just long COVID, but any chronic illness or even acute illness that's lasting for a long time have. And that is that they feel like they are not who they knew themselves to be, that they have lost their sense of who they are. And so my way of describing self-loss is that people who live with a painful gap between who they have been and who they are now are living with self-loss. So I'm going to pause and make sure that that is really sinking in. So if you have an illness and you're thinking about what you cannot do and want to do, there's just this intense experience of that gap. And for many people, it shows up as, I'm not who I thought I was. I can't be who I want to be. And it's an exceedingly painful experience. And if you are a person who has family, neighbors you're close to, colleagues, friends, they have a matching or a corresponding experience. And we call that an experience of ambiguous loss, because the person's there, but they're not the person they used to be. And so the partner, friend, the neighbor, the employee, the colleague is also in a kind of a gray zone of often longing to have, the old person back, but the person's there. It's just that they're not who they were. And so we say that there's two sides of the coin. There's self-loss, ambiguous loss, and how people manage these two experiences that are so intimately connected to each other can be very complicated. So it can be managed very sensitively and well, but it can also be managed in a way that it produces a lot of conflict. One of the ways it can produce a lot of conflict is these long-term questions. The patient is saying, am I going to be able to earn a living? And am I going to be able to care for the people who depend on me? But if the person is relied on to earn a living, the person who's the partner, family member may well say, I'm going to use a he because we have a photograph of a man. Is he going to be able to support us? And am I going to be able to depend on this person? What's going on here? And how long is it going to be before we return to the way things were? All of this kind of thought process and living with each other produces a mental health burden, and it can arise in a variety of forms. People have sleep-wake disorders, anxiety and fear, even trauma and stress-related disorders, and people can start using a variety of medications. They can be prescribed antidepressants, sedatives, anti-anxiety medications, and sometimes there is utilization of opioid analgesic medications that are not prescribed. So here again, what we see in a survey that was done in March 2024, almost 79% of people who reported long COVID said that it limited their activities either a lot or a little. And here, this graph, there's a lot to unpack, but I think the important one is that 24% of people ended up continuing to work, but it meant that they had to limit their activities outside of work. We know that it produces food insecurity. 42% of adults with current long COVID are experiencing food insecurity. There are problems with housing costs. And so again, what does all of this mean? And what we understand in the Witness to Witness program is that when you are a healthcare worker, a friend, a family member, you are in the position of being a witness when you know somebody with long COVID. And what does that actually mean if you are a witness? This is a diagram that I've been working with since the 1990s, and I'm going to walk us through it as if I were the family member of somebody suffering with long COVID. So I want to be in that green square, meaning I want to be attuned and thoughtful and helpful. I'm aware of what's going on, and I feel I'm empowered. I know exactly how to help that person. But we know that that just doesn't happen very often. And instead, I am much more likely to be aware of the suffering of my partner. I really don't know what to do. I'm confused, I'm uncertain, I feel inept, and I feel horrible about it. Now, when I am feeling that way, I could withdraw. I could say, you know what, I'm just gonna forget about it. There's nothing I can do. I don't know what to do. I'm gonna opt out. Of course, that's not very functional for anybody. Or I can just be so frustrated and confused that I lash out and I end up being critical or say something hurtful that just is definitely not going to make the situation better. Now, this diagram fits for physicians, clinicians in this moment as well. Namely, that many primary care physicians and even specialists who are working with long COVID patients can feel that they are in that yellow square. They don't know what to do, or they have a patient who, after working with an occupational therapist, a physical therapist, is still not getting better. So they continue to feel uncertain, and it can be very demoralizing. So caring for somebody with long COVID is absolutely confusing. The medical course varies. People have worries about the impact on every situation that they are involved with. And the actual experience can vary day to day, where somebody feels mildly or very ill. So what do I do? How do we provide symptomatic relief? It's just very unclear what to do and where to get specialized services. And we've seen that for a population in this country where there are about 15 million people, but only about 400 or 411 clinics, somebody could be very far away from getting a specialized service. So this often leads to people feeling demoralized, overwhelmed, and exhausted, which is, any of those are a form of empathic stress reactions. So it requires a lot of work on the part of the patient or the patient's family to get medical care for long COVID. And long COVID patients describe that being a patient is a full-time job, and being an advocate is an overtime job, and it can lead to anger, frustration, and despair. So again, we're looking to ahead that 5 to 10% of adults in the US may continue to experience long COVID at any point in time. And the research is burgeoning, it's fantastic, but the research to improve diagnosis and treatment, it moves slowly. And what we've seen is that it leads to food insecurity, difficulty paying rent. People have had to stop working, and we have 14 to 17 million people with long COVID. So what can family members do? And if you're a clinician, this is something that you really want to be able to tell family members who consult you. It does make a difference if you are a good listener. We talk with people about making it a we, not a you experience. So the sentence is, you are not alone. We are in this together. Actually make a difference to people. You may have to be an advocate for the healthcare system, and then help people remember most people will get better. What can clinicians do? Well, similarly, understanding and empathizing with patients and family members who are coping with long COVID and that long aftermath is really important, and it really does make a difference. Use available guidelines to establish if workman's compensation is available to your patients. And we have a resource that links to state policies. And here's a kind of I think, important one, but perhaps not one that a lot of people think about. Because vaccination is shown to reduce long COVID, it turns out that some patients and families have significant shame that they're dealing with long COVID because the person refused to get vaccinated. So something a clinician can do is help them minimize the shame and put it in perspective. They may be in a work situation where they couldn't get to a vaccine clinic, or everybody in their work site had disinformation about vaccines and said that it was a bad thing to do. Feeling ashamed because they didn't get vaccinated is not going to help anybody. There is an article in the Annals, also published last week, about models of care for treating patients with long COVID. And these are 5 core principles. And I think when you read them, you'll see that they're similar to the principles of good care for just about any diagnostic category. So having a core lead team, having multidisciplinary expertise, comprehensive access to diagnostic and therapeutic services, a patient-centered approach, and then this last one, which we've seen is going to be very hard to do, providing capacity to meet the demand. What about Paxlovid? Well, again, a recent publication in the New England Journal suggests that it is reasonable to recommend Paxlovid for older patients, for those who are immunocompromised, or who have conditions that substantially increase the risk of severe COVID. But Paxlovid does not reduce the risk of long COVID as we had once thought. Another study does show that vaccination seems to lower the post-infection symptom picture by 43 to 58%. So we highly recommend that clinicians recommend vaccination as something people can do to decrease their risk of long COVID. And circling back, physicians who care for long COVID patients are at risk of burnout and depression. And so caring for yourself, using your colleagues to support each other, and knowing that anything you do is something, and any something matters. But it is really important to recognize that you're a witness. You may be in that yellow square, and it's by supporting each other and really paying attention to the impact of your understanding and empathy and being in a we relationship with your patients that is going to make a difference. Some of you may want to take on advocacy roles, providing universal paid leave, making workplaces more accommodating. There are lots of places to do work as an advocate. We're now sort of moving into the Q&A, but before I do that, here are some resources. This was in the beginning, physicians and healthcare providers were really slow to support people who identified themselves as having long COVID. And so there was a patient-led research collaborative, and they have lots and lots of resources for long COVID researchers and also clinicians. On June 5th, the National Academies is going to have the first in a series of webinars related to their detailed report on the current status of diagnosis, treatment, and prognosis of long-term health effects related to long COVID. So if this is a topic that interests you, I really urge you to sign up for this. You can register through this link. And finally, we have additional resources. And we will be asking you to take a look and fill this in. But first, we're going to turn to your questions. So thank you very much.
Thank you so much, Kata. I'm going to ask a question.
Mhm.
Since those that have long COVID-19 don't test positive for COVID, we've developed a checklist for patients to monitor their symptoms. I or Pam is going to put that in the chat. Do you know of other tools to help providers? I lost my spot here. Hold on. Do you know other tools to help providers to pinpoint those that suffer from long COVID? For practitioners that are traveling to farms, is there a list of tools or supports they should bring to help with diagnosing long COVID-19?
Yes, and I think if you see this part of the page, we have lots of resources on these on our website with just the kinds of tools that you're talking about.
Excellent. Thank you, Kata. Mary Jo raised her hand. Mary Jo, I'm just going to go ahead and take you off mute so you can just ask your question live. Just give me 1 second here. I got to find you. Go
Thank
ahead,
you so
Mary
much.
Jo.
Thank you so much for this presentation. We've actually been doing a lot of work on this because earlier in your presentation, you noted it's how difficult it is to have exact numbers of farm workers that suffer from long COVID. And we did an in-person survey with 210 farm workers. And what was interesting, I shouldn't say interesting, we found a very high incidence, 40% of them expressed what was symptoms of long COVID symptoms. So one of my questions all kind of run in the same direction, which is one of the things that we found is that that the long COVID care centers are typically located in urban areas.
Exactly.
And they also request insurance. And
Right.
so the big issue is how do farm workers arrive, and how do they how can they access those services? So one of the things that we've been trying to work on is thinking through for the in-camp programs that support farm workers, what are the actual tools that need to be included in your bag of tricks when you go to that, because the symptoms are very long. And I tried to put, I guess I can't enter in the chat, I can't put a PDF in the chat, but we developed, one of the other things that we found with this population is that when the provider says you need to monitor your symptoms, we actually put together a checklist, which I can't put in the chat for some reason, so that when the provider says monitor your symptoms, they're actually putting a piece of paper in that person's hand that's already printed that has a long list of symptoms and has checkbox never, mild, severe, and then kind of keep, week 1, week 2, week 3, week 4. And I think that one thing is monitoring your symptoms, but as you mentioned, the providers say, okay, you're tired, you're a farm worker. So what distinguishes that from being long COVID? And so trying to monitor symptoms over the long term and correlating those symptoms with specific activities seems one way to do it, but it's complex. And one of the challenges, and I wonder if you've addressed this, is helping providers to know what to look for. Does that make sense?
Yes, absolutely. And I want to go back to the very first slide, which is that there are, 5 definitions. Each of those definitions is drawn from a different set of checklists that were developed. They were developed on different populations. One of the, if you look at the resource on the resource list that you'll get about where those 411 clinics, specialty clinics, are located, it will confirm your impression that they are largely in urban areas. They're not necessarily near the places where farm workers are living. We'd be very interested in getting your, and maybe Martha or Pam, you can help Mary Jo figure out how to send her checklist, her PDF to us. This is an ongoing, it's a problem now, and it's going to be an ongoing problem. And you've identified one of the places. I tried to underscore it as well in the set of questions about, how tired is tired?
Yeah.
And from what are, why are we tired? And are we tired because we've just done 12 hours of manual labor? And if somebody says, well, I know what that tired is like, and I've been tired that way for years, this is different, but what are the tools, what are the checklists that are going to get at the granularity of it's different this way, it's different that way? How are we going to do it? It's just a really complicated, nonetheless, a very important set of tools that need to be developed. It sounds like you've done some. We'd love to see it. Thank you.
Yeah, I don't think I could share it if there's a way to share it, but I don't know if there's a way to share it with us, Pam.
Yes. Hi, Mary Jo, this is Pamela. If you
Hi.
could email it to me, and then I can definitely share it with the participants at the end of the webinar.
Okay.
Thank you.
Mm-hmm.
I put my email in the chat for you.
Okay, thank you.
Thank you.
Thank you for your questions, Mary Jo. Does anybody else have a question they would like to ask? Feel free to raise your hand. I can take you off mute.
I just want to note that we did produce 2 videos on long COVID, and I put the link in the chat, I think in the chat. It's been a process of, we started with a draft, and then we field tested it with farm workers, and it terrified everybody. And so we redid it again, and we redid it again. And it underscores what you said, Dr. Weingarten. You are not alone, because that seemed to be the outgoing message that everybody, help people feel somewhat better when they have this terrible problem. I put the links in the chat, and please feel free to use those and share those. And we want people to be able to share materials that uplift the farm workers who are experiencing this. Sorry.
Thank you so much, Mary Jo. And I will, just to let everyone know, at some point later today, I'm going to be sending everyone a follow-up email that's going to have the links to all the resources, including the ones that Mary Jo mentioned from her organization. And then I'm also going to, it will also contain the links to the recording in both English and Spanish, and finally the links to the evaluation in both English and Spanish, and the PDF copy of the slides. Now, the slide, even though they're going to be in PDF copy, they're going to be too large to share over email. So I'm going to give you guys a link to our website where you can download the slides. So that's how I'm going to be sharing those. And I can see that we are at time, so to respect everyone's time, I'd like to thank Dr. Weingarten for the great information. Thank you everyone for joining us and all your questions. And a very special thank you to our interpreters. And as I mentioned, I will be following up with everyone later today. Thank you all for joining us.
Thank you.
You.
Thank you. Bye all.
Thank you, Martha.
Thanks.